Well, maybe we can ask our panelists at this point. I mean, we've obviously got a lot of options now in terms of treating patients with ALI. Maybe we'll start here. Eric, you can talk about what is your algorithm at your center when you see a patient that has ALI at this point?
Yeah, it's funny. I was listening to this talking, and we have these same conversations right now in PE and DVT as we're having in ALI is
Very
moving
similar.
away from a lytic approach to a mechanical approach.
Yeah.
I had the Lightning 7, so primarily when I run into these cases, a lot of my cases end up being access site complications, large bore access with thrombus that ends up collecting next to the sheath. And that's been pretty successful, and I think that I've had some wins and some losses there. I still like to put distal protection down if there's a lot of thrombus. I know a lot of people don't. I also, as an interventionist, have a hard time giving up my wire, and I'm sure everybody here has a different approach. I don't know if anybody here has experience with the pounce. The other thing that's happening, again, on the PE DVT side that's moving to ALI is more grabbing and extracting clot than aspirating clot, and especially from a blood loss. Has anybody used pounce that are from Surmodics at all? That's another device we didn't discuss, but it has more of a cage-based approach for removing an arterial clot, and I'm interested to see how that might change treatment strategies moving forward as well.
Christian, you're a busy vascular surgeon. You've been doing this for a long time. I'm not saying you're old. I'm just saying you've been doing this for a long time.
I am.
Senior guy. But how has your practice changed over the years in terms of how you approach someone with ALI now? With all the devices that Elizabeth talked about, we've obviously got catheter.
I think if we use the metric of technology changing natural history, the answer is heparin did that back then. But from there, I think the patient presentation continues to dictate our management. Patients that are irreversible, you don't want to reperfuse them. Don't be a hero because you will actually kill them for the reperfusion. The 2Bs, I believe, when you have motor deficits, it's the complicated. I'm looking forward to what they're going to answer, my colleagues in vascular surgery. What do you approach that 2B? Because the 2B, the nightmare is that 2B, you don't have a lot of time, that with your hands and with a wound, you're going to get to the vessel, but then you start having that 2 a.m. in the morning bypass or multiple cut downs for thrombectomy, and they're all vessel disease, and then you end up really, really not very difficult. So that is the subset that I believe technology hasn't yet answered, and that will be interesting if we develop some sort of approach that can deal with those. Minimal invasive, yet expedite. And the mechanical thrombectomies for large burden of disease, in my humble opinion, it doesn't work. So I think there is an unmet technical to that particular subset of patients. And addressing my experience over time, yes, definitely transition from open into aspiration, no doubt about that.
So how much motor deficit is too much? Right? That's the big question, right? It's an experience thing, obviously, but I think when it's obvious, it's obvious. When it's subtle, it's subtle. So maybe, Elizabeth, you can help me out with this.
I mean,
for us non-surgeons, what do you look at, or what is help telling you, okay, I need to take this patient to the OR, and then how do you determine I need to do a fasciotomy at the same time, or do I do it in a delayed fashion?
So if I think about a fasciotomy, I'm doing a fasciotomy. The only people I do not do fasciotomies for are essentially very mild sensory deficit that they come in, they can feel, but they have a little bit of some paresthesias, and you wait maybe 24 to 48 hours till your OR is available or your cath lab is available. Otherwise, if you have a pretty dense paresthesia or any sense of a motor deficit, we're going to be going right away. And if I'm taking you urgently to the OR, you're also going to get a fasciotomy. We have great devices that can help expand tissue externally, so you can close those in a delayed fashion in a day or two if they end up not, requiring and bulging and needing the fasciotomies for a prolonged period of time. If the leg is insensate and they cannot move at all, then I think that's when we say things are too far gone. But if it doesn't look like the leg is permanently damaged, but there is a pretty good motor deficit, I'll still go ahead and try.
Rajesh, let me ask you a question. I mean, I'm trying to be a little bit, controversial here, but if I can revascularize the limb rapidly with some of these devices, why do I need to take them to the OR? Can't I just do that and then you do the fasciotomy afterward? Do you need to take them to the OR? Do you need to do an embolectomy, make incisions? Is it that much quicker?
It's not an easy question to answer. I think you have to go back to the basics. For me, yes, I do both techniques. I'll do endo and I'll do the open surgery, and then I think it depends on what Rutherford classification they are. and what I think my chance of success is going to be. If I think this is going to be a super complicated open case where I'm going to spend 8-10 hours doing this operation, it's probably may not be the right choice. I may have to do an endovascular technique. We may have to lyse them. We just have to kind of bite the bullet and go that way. So it's not a straightforward thing. I mean, it's pretty rare that we lose limbs, in patients that have ALI. I mean, I think the 2Bs, I think majority of us has probably saved most of them that we do. And I think it takes a little bit of experience, I think all of us are pretty far out that we have a good eyeball test. Yeah, this would work. This probably wouldn't work. If it's a popliteal aneurysm that's thrombosed, then you're going to be in a little bit of trouble. Those patients are pretty far advanced, and open surgery may not work. I mean, you have to lyse them, you have to bite the bullet, and those are the patients that may end up with an amputation, and you kind of know that. So it's really a combination of everything. Your basics, your toolkit, a little bit of trial and error. If I can do it fast in an endosuite, absolutely. Elizabeth, just finished my talk. You said if you think of a fasciotomy, do it. That was my whole. That was my one slide. Thanks, Elizabeth. After 15 years of practice, that was my one slide. If you're thinking about it, just do it. Yeah. So
thanks,
exactly what I tell the residents.
Thanks a lot. So, John, Dr. Wiley, tell me, if you're going to use a device, what is your device of choice? Do we need to know more than one? Can I just be an expert at the Penumbra device or Jetty, et cetera? Do I need to know more than one?
So I think it all amounts to what you have in your lab. Number two, how much time you have available. Brian showed in his slides what is the algorithm that probably most of us use. If you have a stage 1 or at the most a stage 2A, where you just have a little bit of sensory loss, no motor deficit, then you could try any one of them. Nowadays, I think that using aspiration thrombectomy, the device, rheolytic thrombectomy, if that works, then I think that's probably the first choice. If you're unsuccesswe with that and you still have some time available, then lysing, has shown to be beneficial. But if you really don't have much time left, if you're in a stage 2B, then you probably should be calling I'll be calling Brian or Raj to help me out, because it's really out of what I have available to help him.
Ryan, if I'm your fellow, how do you teach me on day one? Is this something I have to learn over the course of my fellowship? Obviously, experience helps and so forth, but how do you convey the message to your fellows or your trainees in terms of how you're going to approach a patient with ALI at this point? I mean, the obvious ones are obvious, they have to go to the OR, but the ones I'm saying that are kind of in that middle gray area.
I don't think you can teach that to a fellow on day one, I'll tell you that. There is a gestalt that comes over a number of years seeing these patients. But there are some pretty hard and fast rules in between there. And I'd say one of the hard and fast rules is that in patients with sensory deficit, you generally have some time. You could lyse them overnight. You could use thrombectomy catheters. You could do embolectomies. You could even bypass those patients. If you have someone who's progressed to motor and sensory deficits, those have to be fixed very quickly, and you don't have a lot of time. And so that's where lytic therapy overnight is not a good option. If you're successful at using thrombectomy catheters in a patient like that, that's just as good as a bypass or a open thrombectomy. But you can't, they don't always work. The problem is then you start going down a path of an emergent surgical bypass, and those are not good options for these type of patients. And the other thing I'd say that I teach my fellows is that everything has its risk. Lytic therapy has its obvious bleeding risks. Aggressive strategies of thrombus removal have a more of a risk of embolization and unfixable embolization. So you kind of got to balance those out and decide which of those risks you're gonna want to assume. So,
I mean, as a non-surgeon, I'll tell you, we have 5 vascular fellows or peripheral vascular fellows, and the way we do it is, we tend to be pretty conservative. If they have sensory loss but and their motor function's intact, we'll obviously take them and do everything endo and do what we can. Then the next set of questions will be, do you do catheter directed or do you do, a device? Do you have to do a device? If they have, any level of motor deficit, that's usually when we call our surgery friends and say, look, what do you guys think? What should we do at this point? Because we don't want to burn any bridges at that point.
And
regarding catheter,
to that effect, we are talking about lower extremity acute limb ischemia for those of you who are here. And virtually seeing the symposium, the upper extremity behaves differently. And
Absolutely.
And sensory deficit is all the endpoint you need to trigger.
Yep. No, it's a great point. You don't have as much time with the upper extremity. In terms of catheter-directed thrombolysis, let's say you are going to do CDT. Do we need, first, does catheter position matter? That's the first question, in terms of where you put it in the clot. You know, there's a lot. I'll tell you, years ago, you'd stick it in the proximal part of the clot. Maybe you'd image them, maybe you wouldn't. You'd come back, some of them would clear, others wouldn't if they had more subacute or chronic clot. Now it's, do you have to lace the entire clot? What's your TPA dose if you're doing CDT? And also, do we have to track fibrinogen?
Well, I'll take the first one. I mean, we've been pretty aggressive about, we primarily use ECOS for our CDT, and we're pretty aggressive about placing it, and as you mentioned, lacing or crossing the clot. So we'll use even more than one catheter if needed to get as much clot removal as possible. And again, it's a balance of bleeding. We check fibrinogen. I can't say I make a lot of decision making off of it. I try to move away from that a little bit. And but I think that we found that we have better outcomes when we're really aggressive in terms of placing these catheters, if possible. Sometimes it's not possible, across the clot or as much into the clot as possible. I'll defer for duration and dosing to my colleagues here.
Christian, what's your dose of TPA? Are you giving a bolus? A lot of surgeons like to give boluses intraoperatively because you do that for various things. What's your algorithm in terms of TPA?
To be honest, in the 2As...
Arterial.
Yeah. In the 2As, when they come and they are catheter directed, I actually call my IR colleagues. So like you do for the 2Bs, we respond in kind, and the 2As are yours. If we're talking about intraarterial, because whatever option the aspiration is not clearing all the way, and then you need to leave it overnight, I usually have my little formula I use, and I just drip slowly and steadily because the burden mechanically is done, and I'm just clearing the outflow, if you may.
And then what's your thought on fibrinogen at this point? Do I need to track it?
I don't.
Does it matter?
I don't know.
Yeah. Elizabeth, what do you think in terms of your TPA dosing?
I'm very traditional, so I'll give 2 milligrams intraoperatively. Now, this being said, I think we're having a lot of mutually exclusive conversations. I don't think any of this stuff is mutually exclusive. So I think there's no harm in trying to clear, as long as you're doing it safely. I think the comment about embolization with some of these single session use, you do have to be conservative. So I will often use these technologies over a filter wire. You do lose a little bit of your suction power, but if that doesn't work, then I will drip overnight. And so for me, I'll lace with 2 milligrams if I haven't already just used angiojet, and then I will run at 1 milligram per hour. And I do follow fibrinogens. I've never had to adjust base off of it, but I just don't think I'd be able to sleep.
We check them. We're just
I don't know if I'd be able to sleep without checking them. I don't know. Maybe it's just to make sure that
And I'm
people
being
are
a little
looking
bit
at the
black and white. I
patient.
mean, I know we're going to be doing hybrid of a lot of this stuff,
Yeah.
but I think for people out there that don't do a lot of ALI, I think it's good to kind of compartmentalize. Right? Rajesh, what do you think?
So, I'm also old school. I do give a little bit bigger dose. So I usually power pulse spray them at 10 milligrams. Occasionally I may, if I'm using an angiojet device or something, I may wait for 20, 30 minutes and debulk some of it.
It's very venous-like, by the way.
Yes, and then drop a lytic catheter at that point. So I've got a little bit of a head start there. I do check fibrinogens. There are times that I have adjusted dose based on fibrinogens. Now, have I had a very bad bleeding outcome? Because, you can have a normal fibrinogen and a bad outcome. But I think medical legally, I don't know how, if you're not checking, if you have a bad outcome, it kind of puts you at a little bit of a risk, I think. So that's something just to keep in mind. But that's usually my protocol. Somewhere anywhere between 0.5 is probably what I shoot at.
0.5 milligrams an hour?
After
you've given 10.
Yeah, I've given 10. So I like to start a little bit slower. I would go at 0.5.
How about you, John?
Well, I think it really depends on the patient. If it's an older patient, that I think that there may be an increased risk of bleeding, I'll probably start with 0.5. If it's a younger guy, that the risk of bleeding is lower, I'll probably start with 1. Sometimes I've even started at 2 milligrams an hour. I do follow fibrinogen. I don't know if if it has truly any meaning or not, but if it's less than 200, then I start thinking and other alternatives, and probably switch from doing thrombolysis to something else, or calling my surgical colleagues.
What do you think, Brian?
I think it's fascinating the differences on the panel here.
That's the reason
I will say that I follow fibrinogens. I'll taper the dose if it drops by 50% over one check over 6 hours or goes below 200. I used to do 2 milligrams an hour for 2 hours and drop it to 1 milligram an hour from that point forward. And then I saw some of my IR colleagues in Los Angeles were doing these ridiculous doses of 0.125 milligrams, and I thought that was insane. But I will say, over the years, I've actually migrated to doing exactly that, because once you're giving 2 milligrams, you can give 10 milligrams an hour or 10 milligrams right up front. It's going to be gone in an hour, But if
the half-life is short.
Right, but if you're giving continuously at 2 milligrams or 1 milligram an hour, you start seeing, I've seen at least precipitous drops in my fibrinogen, bleeding problems, and once you get a bad groin hematoma, you're done, or it could be done. And so I have actually now, I never give a milligram an hour. I hook them up at 0.5 or 0.25, and I've seen better reperfusion results with fewer bleeding complications, I think. So that's what I do.
But I think that's the point I was trying to get at. It's all over the place, right? And we don't have any data on what's a good algorithm for TPA dose. Do you lace? Do you not lace? Catheter position? Do you have to track? I think most people will track fibrinogen for everybody that's learning about this, because it's kind of like what a lot of people do, and you feel like if you don't and something bad happens, then what do, right? Again, if your fibrinogen is 500 when you start, then you feel a little bit better about your TPA and you've got some time to kind of, lyse the clot. If your fibrinogen is 150 when you start, now you're a little bit more, I think it raises your awareness level that, I better be a little bit more careful and watch this patient. And what Brian said, he's right, 0.1125, I mean, I don't know. I think that's the old Redivase days, when we're giving Redivase for, when urokinase went off, then it was Redivase, then this, and all this stuff. But I think with TPA, 0.25, 0.5 makes sense for arterial. I think it's length, it's duration, right? It's surface area. Those are all the things we think about, so.
Question.
Yeah.
So we have a lot of new thrombectomy devices in the past year. I feel like Lightning 7, the Jedi, the Bounce, you got a lot of different products, but we used to do a lot more CDT. When do you guys do CDT or versus just going in with a thrombectomy?
So when do you do solely catheter-directed lysis and no thrombectomy versus thrombectomy?
No, historically I've lysed overnight and then bring them back and try to see what I'm done with. But I feel, there's a time of you're waiting and you're kind of nervous. You don't know what you're going to deal with. Sure. Is there, when do you decide you're going to lyse the guy for 10, 12 hours, bring him back and take a look whether you're going to, balloon or do thrombectomy versus you just say,
great question.
I just want to go straight thrombectomy and.
Yep. So let's talk about endpoints. You start lysis. Let's say you decided, I'm going to lyse this patient because their outflow is bad. I want to open up some collaterals. I want to open up some small vessels. You start lysing. When do you decide to bring the patient back? How long do I wait? 4 hours? 12 hours?
I like the 2 milligrams of TPA intraoperatively because it tells you how well it's going to respond. And if you start clearing a channel with just that, then I go for it and I try to clear it all in that single session. That's when I pull out my thrombectomy catheters. If I don't see a lot of change with that, or if something about the history suggests that this has been somewhat, it's been there for a week, 2 weeks, it's not something just happened that night, then I'm going to be a little bit more inclined to drip overnight because I know I'm not likely to have a good result with a slogging away for 4 hours in the cath lab. So,
do you carry the risk of clinical worsening if you keep him just dripping overnight?
Again, that's where your presentation matters. So if you already have some motor deficits, then you got to be very cautious about dripping overnight. But sensory deficit, mild sensory deficit, I have not seen that be a real problem.
So Brian, if you started your lysis at 9 in the morning, you'd wait till the next morning versus if you started at 5 p.m.?
Yeah, I'd go up to 24 hours. I mean, sometimes I'll bring them back that same day. Some of that's logistics of the.
Would you change your dosing at all? If you started at 8 in the morning and you're planning on bringing them back first case the next day, would anybody change their dosing based on that, or just go with it, and as long as they're doing okay on exam, you just continue and just plan on bringing them back the next morning, unless there's an acute change, obviously.
I mean, for me, if I'm going to try to bring them back later in the day, I'll probably up that dose, but typically I'm 0.5, 0.25.
Not changing too much.
Yeah.
Yeah, if you check after 12 hours, you're starting to have resolution of a thrombus. It means it's working. There's probably no reason to increase or decrease the dosage.
Yeah.
It all depends on what you find
It's funny how logistics, though, definitely determine duration of therapy.
big-
And we all know
Absolutely.
this, and this is, and again, on venous thromboembolism too, but I
Also,
think
your
it's
physical,
important.
and then your physical exam also will kind of may help guide you as to,
Yeah.
okay, well, foot looks warmer, foot looks well
Yeah.
perfused now, you have signals or whatever not, and then
You have
might be able
time.
you might start tailoring things accordingly at that point. Then, okay, I may want to bring him back now, or I may be able to finish off at this point, beat the underlying whatever anatomic issue there is.
What about contraindications? History of stroke. How old does that stroke have to be? History of TIAs, prior cancer, prior surgery, chest tube. All the classic things that we get called about. Oh, we just put a chest tube in this guy. Oh, but now they got a cold limb. Does that now change what all of you do on the panel? Do I have to worry about somebody that has a history of lung cancer that's been treated? They've had a resection, they've had radiation, they don't have any Mets, they're clean on their most recent PET scan, their recent scans. Do I have to worry about brain metastases? Do I need to scan these patients? What is the panel's thoughts on that? Because this is kind of a common question, right? An everyday question, a lot of these patients.
I mean, it's rare that we have a patient that doesn't have at least one on the checklist for at least
Something,
relative or absolute, So I think everything's a, discussion. I mean, we definitely been, if we can, it's easy to get a CT scan of the brain for that patient with an unknown potential metastatic disease. That's quick and easy. But, I think the single session and mechanical thrombectomy has helped a lot. So if you do think you have a relative contraindication, we always keep TPA in the lab, but trying to do that as our primary approach, and then some local delivery and maybe not extended duration therapy if we can get away with it. But I think that it depends on what you have available to you in terms of treatment options and how large that contraindication is. I'd say the vast majority of these are usually relative and not absolute, and we're able to get away with some TPA and safely enough.
Yeah, the easy answer is the absolute contraindication, you're not going to thrombolize. The problem is those that have relative contraindication that puts us in a difficult spot.
Ulcer.
Which, all those are the ones that you're going to have to risk and benefit. Perhaps if they have a relative contraindication, then try to use aspiration thrombectomy, rheolytic thrombectomy, before you think of putting a licensed catheter.
I was going to say one thing.
Yeah, go ahead,
When I was a fellow, we had a patient who had a spine injection or pain injection done, and she forgot to tell us that. And and we lysed the patient. And so now I changed how I ask my questions also. Has anyone stuck or done anything besides blood draw anywhere in your body? Your eyes, your back, your spine. Obviously, they'll tell you your major surgeries and all that stuff that they've had. But things like eye surgery or something they may consider minor, or pain injection, which they may consider minor.
Recent falls, even.
But could be a big thing for
It only takes one complication like that to change your entire approach.
Oh yeah,
right?
this was like
we've all been there.
Yeah, 15 years
exactly.
ago, and it turned out to be a big lawsuit, and
Yeah.
and you change your practice that way. So you have to be. These
Yeah,
things
you
can
get some
happen.
really bad epidural hematomas after just,
And I definitely do document that. We have like a little, smart
Checklist,
chart,
yeah.
but just a checklist.
I mean, most of us have checklists, but
Yeah.
for a lot of people that are learning and
Yeah.
stuff, I know our fellows don't think about a lot of these
Right.
things to ask. And it seems very kind of second nature, I think, to most of you, I'm sure, that, it's kind of good questions to talk about. If you had to keep one or two devices in your lab for ALI, which devices would you keep, Brian? You only get two.
I'd probably say the 8 Wolf and certainly the Lightning 7, and the Penumbra Lightning 7.
John?
Probably stay with the Penumbra and the Angiojet. The other ones I have not used. So.
And the Angiojet? You like the Angiojet? Okay.
Yeah, those are the same two that I have too. And so
What about you, Elizabeth?
Yeah, absolutely.
Same two. Christian, I know you refer out.
Penumbra.
Penumbra, yeah, that makes sense.
And we keep ECOS. I mean, that's just, we've used it a lot in Penumbra catheter.
Penumbra catheter, yeah. No, it's just amazing when you talk to people about all this stuff. It's like PE. It's exactly like PE.